Delighted to have with us our friend from Philadelphia. We see her every year here at Asco, Edith Mitchell, MD. She's a medical oncologist at the Kimmel Cancer Center of the Thomas Jefferson University, and she's also the director of the Center to Eliminate Cancer Disparities there. And I know that's what we're going to talk about, but last year you got a very prestigious award, the 2012 Asco Humanitarian Award. A year later, how has that sunk in for you?
Well, one of the greatest things that can happen to any individual is recognition by your peers. Mm-hmm. And when you do extra work, especially with people and patients, communities, and you have it recognized by your peers, that's a tremendous accomplishment. And I really so much appreciate my peers from Asco who so kindly recognized my work. So it was a privilege for me to accept that award, and I am still very much in awe of the event and the recognition. And I'm very much appreciative to Asco and my peers at Asco for that recognition.
Going the extra mile has always just been part of the journey for you, hasn't it?
That is correct. I always enjoy doing that extra bit, going the extra mile for people, and it always pays off. That's what I did in the military, and while I always did my regular job in the military, one of the things that I was recognized for was understanding people and making sure that all of the military components had the best medical care that I could set up for them. That's so important.
Let's talk about disparities now. What are the disparities in cancer and who do they affect?
Well, disparities in cancer really covers a large topic, one that is very interesting. So when we look at different populations within the United States, for example, the Latino population, the African American population, or the Native American population, these are all communities where there has been either a lack of access to medical care or certainly some differences in the incidence of medical problems or either in mortality rates. So when we look at mortality rates in the United States from cancer, note that we have made tremendous strides, and over the last 2 decades there has been a substantial decrease in cancer mortality. Still, the differences between populations, between the standard, which is considered the Caucasian population in this country, and that of the disparate populations, there's still differences, and that gap is actually larger now than it was 20 years ago. So we've made improvements, but not improvements, or not as much improvement in the minority populations as we would like to see. Consequently, those differences are even greater now. So when you think about the fact that by 2030, minority populations in this country will become the majority, and the Caucasian population, it is estimated, will be the minority population. And the fact that cancer incidence in many cases is higher in the minority populations, as well as cancer mortality, I think we're going to see, rather than a continued decline in mortality rates, we're going to see less decline and perhaps even an increase in mortality rates. So I think it's so important to make sure that we are addressing these issues in the minority populations. And the issues are not all socioeconomic. There can be molecular differences. For example, triple negative breast cancer. triple negative breast cancer occurs at a much higher rate in the African American community. And triple negative breast cancer, whether it occurs in a Caucasian woman or an African American woman, is a challenge in terms of treatment and surveillance, because while these patients' tumors respond to chemotherapy very quickly, the options for treatment are limited. So we need to develop new drugs. Recurrence rates are very high immediately after completion of therapy. So we need better treatment, and we need to evaluate what can therefore keep these women in remission from cancer longer. So preventing recurrences, very important. The molecular features of the disease. So for triple negative breast cancer, estrogen receptors, progesterone receptors, and HER2 receptors are negative. So therefore, understanding the molecular features of the disease. And this has really been demonstrated in breast cancer. But for other cancers, for example, colorectal cancer. Colorectal cancer has a 20% higher incidence in African Americans and a 40% higher mortality rate. There are higher numbers of poorly differentiated colon cancers. So therefore, again, challenging clinical entities, and yet we don't understand the molecular features of the disease. Are there some differences that we need to address? Metabolism. Metabolism is very important, and about 20% of African Americans in this country have G6PD deficiency. Does that affect the metabolism of drugs, thus accounting for the higher mortality rate? So we don't understand all of the clinical components of the disease processes, and therefore I think that increasing the number of African Americans in clinical trials, for example, very important. For most drugs that are developed in this country and approved by the FDA for marketing, the participation of African Americans in those trials is is very low compared to others. So, and it's not because African Americans won't participate in clinical trials, aren't interested in clinical trials. They are, but there are some cultural factors that might affect individuals participating in the trials, but also whether or not the providers even present the trial to African Americans, because what we find is that many individuals who are involved with the development and administration of clinical trials believe that African Americans won't participate, and consequently the offering of a clinical trial may be impacted. So there are lots of areas where we need to evaluate, perhaps develop different strategies. We don't know, but research, therefore, in these areas, both in terms of population science and in terms of basic science to understand the disease processes in various populations.
Let's talk about younger people, the younger population. How do you perceive them?
It's very interesting. We have recently had a paper accepted for publication regarding young patients with colon cancer. And again, what we have, younger patients don't undergo screening because they have not reached that 50-year age group where routine colorectal screening is recommended. But yet, the number of young individuals who are less than 40 years old developing colon cancer is increasing. So while we're seeing a decline in overall incidence of colon and rectal cancer, the incidence of colon cancer in young patients is increasing. For many of these individuals, when they complain of abdominal pain, for example, the last thing you think about is a colon cancer. So consequently, not only is there an increasing incidence of colon cancer in young patients, but these patients present at a later stage because they have had symptoms, usually for quite some time, that have been attributed to other benign processes. So understanding the reason for this, we don't know. Some of my colleagues in gastroenterology have explained to me that they think it might be because of the increasing use of fast foods, and whether the fast foods, there's so much we don't know, but we do believe that one, this is a disparate population, and therefore we need to investigate further the etiology and perhaps develop some preventive strategy in younger patients, but also to make sure that they get into the appropriate therapeutic regimen and therapeutic interventions that might offer the best outcome for their disease process.
Well, you keep looking out for people, all people.
I do.
Congratulations on another fine year of work.
Well, thank you. Thank you so much. It's always a pleasure to see you and to work with you.
Okay, dear. Dr. Edith Mitchell from the Kimmel Cancer Center at the Thomas Jefferson University in the great city of Philadelphia, PA.